Well, we're going to move into ethics at the edges of life. And if we look at that same diagram I showed earlier, again, you'll see that it's the box and who's the referee at the beginning and the end of life is where a large number of ethical decisions are made, particularly in a hospital setting. Whoever controls the language often controls the debate. So social engineering is preceded by verbal engineering. We'll see that with conception. Conception used to be fertilization. It's now been redefined by the College of OB/GYN as implantation. Somatic cell nuclear transfer, that's the fancy word for cloning. Therapeutic cloning is when you destroy an embryo to get stem cells. Selective reduction is when someone is pregnant with more than one and they use what's called a feticidal agent, where they actually kill one of the babies and it kind of involutes because they don't want to have more than whatever number they're carrying. Usually it's done for a twin or quadruplets. My body, my right. We all know that the baby is not actually a part of the mother's body. Right to die, compassion in dying. These are euphemisms for assisted suicide and euthanasia, death with dignity. These are organizations that use those terms to soften what they're actually doing. So if we start at the beginning of life, there's a number of questions that come up often with people who are struggling with decisions. How far can you go not to get pregnant? What types of birth control, if any, can you use? How far can you go to get pregnant? What about artificial reproductive technologies? How far can you go to have a healthy child? Prenatal genetic diagnosis or genetic testing. How far can you go to have a natural birth? Will you actually put your child's life at risk and refuse a C-section? What if you're pregnant and don't want the child? What if you're being pregnant threatens your life? What if you deliver a very sick or disabled child? So, beginning of life. Fertilization is when life begins. It's when there's a new genetic human being that has a unique genetic profile that will stay that way throughout that person's life. That's what we often refer to as traditional conception. But now implantation is neoconception, where in order to call certain methods contraceptive, the term implantation was turned to conception. So methods that block implantation are called also contraceptives. And they argue that, 50% of the embryos don't implant anyway, but this also allows for forms of birth control like the IUD and the morning after pill. Some will say the beginning of life starts at 14 days. In that, there's several events that occur. One is the beginning of the primitive streak that eventually forms the brain. So the embryo has some brain function at that point. Also, twinning can no longer occur after 14 days. So some would argue, if you have an embryo and it can split into two, how can you say that that's a person if it can eventually become two? So that's an argument that's used. And some will say 22 days because that's when the heart starts beating. And Old Testament sometimes talks about the life blood. So blood starts circulating at 22 days. 40 days was some Jewish traditions. If we go back into the Talmud, they refer to before 40 days, it's only fluid. And so it's not uncommon for some in the Jewish community to use that as a cutoff, which allows for some early abortions and prenatal testing. Some would argue that quickening, when you first feel the baby move, which is around 18 to 20 weeks. Viability, survive outside the womb. Well, it depends on when you ask that question. So, 50 years ago, viability wasn't 24 weeks. When Roe versus Wade, it was around 28 weeks. Now it's somewhat even younger than that. And we'll talk about artificial wombs. It might even be earlier than that you can have viability. Some will say when the baby takes a breath, that's when it first becomes a person and life begins. Or Peter Singer, as we talked about earlier, sometime after birth, 2 months, sometimes 2 years, he might even go with. So there was a cartoon out a number of years ago, and it started off as the title was Modern Morality. Is a fetus a person or is it a thing? And the women talking, one of them said, well, it's simple. If you want it, it's a person. If you don't, it's a thing. And that's kind of our conventionalism or postmodernism. You can alter the truth to fit your purpose. But we know that God created man in his own image. In the image of God, he created him, male and female, he created them. To me, one of the strongest arguments for life beginning at true conception or fertilization is the incarnation of Christ. I mean, God could have had Christ come in the appearance of a 30-year-old man already formed. He could have done any, but he chose to conceive inside of Mary's womb and form Christ. And so it was at some point could he have become a twin and he wasn't really God till 14 days? No, he was God from the moment of true conception. What are some of the current issues? And some of these are really within a year or two old. Uterus transplants. Here in Dallas at Baylor Hospital, they're doing uterus transplants. Just within the last few years, the first child was born after a uterus was transplanted. Now, there's nothing necessarily wrong with a uterine transplant for women who had a congenital absence of a uterus or may have lost their uterus for some reason. But we also now have the transgender community that would like to have uterine transplants, or men that want to be able to have the experience of having a child. So that's not been performed yet, but there's no reason that it might not be attempted and in some way be able to make that work. Artificial wombs, technology that was just came out this year with sheep, and they've had premature sheep that were delivered before viability, and they were kept in what's called a bio bag, which they took the umbilical cord and they did almost like a heart-lung machine, or they had what's called ECMO, where they have the blood going in and out through an external device, and then they created artificial amniotic fluid, having it circulated, and then they had to provide nutrition through the umbilical cord with as well as the oxygen. And so they were able to maintain these premature sheep and delivered, and they're perfectly normal. So there's a possibility they may be able to extend viability back much earlier than what we do at this point. Some of you may have heard about this new genetic engineering technique referred to as CRISPR-Cas9. It's an acronym that I won't go into details for the long term that it means, but it's a relatively simple, inexpensive, and available way of doing gene editing, where you can cut and paste defective genes with ones that aren't affected, or there's possibility, although it hasn't been at least described yet, of being able to have maybe more active genes. You might have to enhance properties. This has always been a concern when you edit embryos, and this has happened in China, and the question of whether it will happen here or elsewhere still needs to be determined. But the researchers want to be able to edit the embryo. And the problem with that is that all the descendants of that embryo will have the same change. Now, I've been around long enough to know that medicine's not perfect. And when you think you've got the perfect cure, that you find out later that there's some complications, some unexpected complications that you weren't aware of. And this can happen with doing what's called germline modification, where the cells that can produce future offspring, you may fix the cystic fibrosis or the sickle cell anemia, but there may be some other problem that you weren't aware of, and there could be some downside effect to that. It also could be the haves and the have-not by being able to create children that have abilities that are greater than normal. The 14-day rule. This is not the same one we talked about twinning, but it's somewhat related. Embryo research, there's always been a moratorium on in vitro fertilization that you couldn't grow an embryo greater than 14 days. Part of the problem is it wasn't an issue because there wasn't any way of maintaining that once the placenta tries to form. Well, now there's techniques that they're able to have an implantation occur in a petri dish. And so there's a push now to get rid of that moratorium on the 14 days. So if you're a sci-fi fan like myself, you say, well, here we're extending the in vitro longer and longer. We've got the artificial womb coming back. At some point, there may be true test tube babies where you could actually fertilize and have a child born outside the womb. So it's probably a ways off, but it's not outside possibility. There are also now artificial gametes, and particularly those in the homosexual world and transgender would like to be able to have children that are of their own. But if there's two men, they don't have an egg, and there's a possibility that you could take some of their somatic cells, their adult cells, and actually be able to change it to an egg, and that could be fertilized by the other partner. So these are techniques that are being written up. There's journal articles about some of the preliminary studies on these. So in some ways, we're at the best of times and the worst of times. We have things that are developed that are wonderful. My wife's a breast cancer survivor, 9 years now, and my daughter is a leukemia survivor. So I've seen, and my daughter has a form of leukemia that can be treated with a pill that actually changes the chromosomal makeup of her leukemia. She has what's called CML, and it has what's called a Philadelphia chromosome. And so it's actually a targeted therapy that can reverse that and reverse her leukemia. And that's just an amazing, it's kind of the poster child for these new targeted therapies, and you hear about that for lung cancer and others, where they're targeting the very specific mutation. My granddaughter was born at 27 weeks. My daughter went into labor at 25 weeks, and she was in the NICU for 3 months. And almost in an artificial womb. If you look at the incubators today, they're about as close to an artificial womb as you can get. And she's 15 now and is fine. But so in some ways, medical technology is wonderful. But on the other hand, by being able to change the sanctity of life, the value of life, the inherent dignity, and turn medicine into a science and a build-a-baby market. In some ways, we're into a new eugenic type of environment. Let's look at some of the reasons for abortion. Okay, one reason is to eliminate the pregnancy. It's the pregnancy, not the fetus, that's harming the mother. Mother has some medical condition that the virtue of the pregnancy and the stress and so forth is adversely affecting. So the goal would be to make the woman no longer pregnant because it's the pregnancy. Hopefully both lives would be saved. Or you want to eliminate the fetus. So is it really to not be pregnant? Because we're getting closer and closer with artificial wombs and the NICUs being able to have viability, and the treatment of conditions while women are pregnant have remarkably been successful, and they can maintain their pregnancy. If we look at the American College of OB/GYN statement that came out 1975, this is just 2 years after Roe versus Wade. It says the college recognizes that situations of conflict may lead to a justification for inducing abortion. The college affirms that the resolution of such conflict by inducing abortion in no way implies that the physician has an adversarial relationship towards the fetus, and therefore the physician does not view the destruction of the fetus as the primary purpose of the abortion. The college consequently recognizes a continuing obligation on the part of the physician towards the survival of a possibly viable fetus where this obligation can be discharged without additional hazard to the health of the mother. Well, let's look at a journal article just a few years ago, American Journal of OB/GYN. The title of the article is A Proposal for an Ethically Justified Practical Approach to Offering, Recommending, Performing, and Referring for Induced Abortion and Feticide. So feticide is the direct killing because some abortions have what they considered a complication of having a living child. So they want to make sure the child is dead before it delivers, so they don't get into problems with what they consider a live birth. So as I mentioned about artificial wombs and abortion, this was an article talking about the same issue, the dilemma about is it really for the life of the mother or to kill the child? It says the abortion right has been most vigorously defended as a right not to be a gestational parent, not as a right not to be a legal or genetic parent. The right enjoyed by women is a right to stop gestating, not a right to end the existence of the fetus. My body, my choice would instead become a right to terminate the life of the fetus. Well, of course, they're already doing this, but by eventually having that technology, it's being much more obvious as to what you're really doing is you want to eliminate the fetus. It's not for the health of the mother, it's really eliminating that person. Now let's switch over to artificial reproductive technologies. And I'm going to just show what the guidelines are that the Christian Medical and Dental Association have come up with. And this was a fairly recent document, but it talks about some of the recommendations. It starts off saying fertilization resulting from the union of a wife's egg and her husband's sperm is the biblical design. Individual human life begins at fertilization. God holds us morally responsible for our reproductive choices, and artificial reproductive technology should not result in embryo loss greater than natural occurrence. So these are some of the fundamental guiding principles in discussing some of the different options. So what's considered morally acceptable options? Now, some may feel that none of these are morally acceptable personally, but at least these are the ones that are considered by the committee, and that is medical and surgical intervention to assist reproduction, that is ovulation-inducing drugs or correcting anatomic anomalies hindering fertility, artificial insemination by husband, adoption, including embryo adoption, in vitro fertilization with wife's egg and husband's sperm with subsequent embryo transfer to wife's uterus, and cryopreservation of sperm or eggs, which for sperm it's been around for a long time. Eggs, it's fairly recent. Just in the past few years, the technology exists to have a woman ovulate, or even with the stimulating, have multiple eggs, and have the eggs frozen that could then be used for future fertilization. At first, this was only allowed for special circumstances, like a woman undergoing chemotherapy, but now it's more available on a regular basis. What is considered morally problematic, remember that spectrum of thumbs up, possible, maybe, so at least morally problematic, again, some may have a problem with it completely, but introduction of a third party, for example, artificial insemination by donor, the use of donor egg or sperm, and gestational surrogacy, third part carries the child produced by wife's egg and husband's sperm. And now that's more on a commercial or regular basis as opposed to special circumstances in which maybe someone has had several embryos stored and for some reason they can't carry. They may have a surrogate, a friend, or a sibling, or of course in the case of embryo adoption, and essentially whoever adopts the embryo is a surrogate. So, and that's the same with cryopreservation of embryos. You should only, if you're going to freeze the embryos, you should only fertilize and then subsequently freeze those that you intend to come back into your body. So it opposes discarding or destroying embryos, the uterine transfer of excessive numbers of embryos at one time, selective abortion, which is called embryo reduction or sometimes selective reduction, the destructive experimentation with embryos, true surrogacy, and that's in contrast to what's called gestational surrogate. A true surrogate is you use the woman's own egg and then she also carries the child with a donor sperm, and so that's true surrogacy. And the routine use of pre-implantation genetic diagnosis and pre-implantation genetic diagnosis done with the intent of discarding or destroying embryos. And the guidelines for cryopreservation or freezing the embryos is cryopreservation of embryos should be done with the sole intent of future transfer to the genetic mother. The number of embryos produced should be limited to eliminate cryopreservation of excessive numbers of embryos. There should be agreement that all frozen embryos will be eventually transferred back to the genetic mother. Should it be impossible to transfer the frozen embryos to the genetic mother, embryo adoption or gestational surrogacy should be pursued. So those are some of the more current issues of beginning of life. And now if we go to the other side of the box and we look at end of life, issues of brain death. One is somebody really dead. Is somebody really dead? Is brain death death, or is it just a convenience for organ donation? That's still a topic along with organ donation itself, because there's a movement now to get rid of what's called the dead donor rule. The dead donor rule means that you can only retrieve organs that you want to transplant into somebody else if the donor's dead. Now that's not talking about live donations with kidneys and so forth, but the retrieval of the organs can't be the cause of death. So the person has to be dead, then you can retrieve the organs. So you don't use the retrieval of the organs as the cause of death. There's a large movement now to try and get rid of that. So that would allow for those that want to have assisted suicide to be able to time and arrange for their organs to be donated. They could be just put asleep in the operating room, and then their organs could be removed, and that would be the assisted suicide. Others will say, well, we're going to withdraw life support, and then at a certain time when the heart stops, we'll wait a certain period of time, and after that we can remove the organs, and that's considered donation after circulatory death. And that's done fairly routinely, and usually it's 5 minutes. The heart has to have stopped for 5 minutes. But there was an article in New England Journal of Medicine several years ago that talked about infants being done that way, in which they only waited 75 seconds after the heart stopped before they retrieved the organs. So that, again, is the cause of death removing the organs, or were they already dead, which comes first, is becoming a topic. Life-sustaining treatment is ongoing. Just the other day, when I was listening to the news about the horrible shooting in Las Vegas, they interviewed one of the trauma surgeons at one of the hospitals, and they talked about how many people that got there, are they still alive? And he said every person that that arrived while they were alive are still alive. And most level 1 trauma centers, a lot of them are like that. Once you get to the hospital, you can be pretty much maintained almost indefinitely. So that's a great thing, but it also causes challenges. Physician-assisted suicide is becoming more and more legally permissible in states, and that's going to be an issue for the medical team. Are they going to comply? There was some concern, I think, in Oregon, that one of the large insurance providers said, well, if it's available and they'll pay for it, physicians can't refuse to do it. If you're on our plan, you have to be able to provide all legal options, including abortion. But there was fortunately some intervention, and that was stayed. There are some places where physicians are not comfortable giving the lethal injection, so they're wanting to pass laws to allow nurse practitioners to be able to do that. So that's going to be a continuing problem. And of course, euthanasia, where it's different than assisted suicide, where assisted suicide it seems to be voluntary, but now with euthanasia, it may often be involuntary. So if we look at death, there's a ubiquity of death. Not all of us get married, not all of us get diabetes, not all of us have children, but all of us will die, and we usually have no idea when. So we go back, and I know Dr. Waters talked about this, about the fall. And the Lord commanded the man, you are free to eat from any tree in the garden, but you must not eat from the tree of knowledge of good and evil, for when you eat of it, you will surely die. And so, what are the results of the fall? There's immediate spiritual death. You're separated from God. And then there's the promise of salvation. But the ground is cursed. There's disorder in the physical world and disease. And that's related to what Dr. Waters was talking about, is where does illness, disease, disability come from? It comes from a fallen world a majority of the time. A child born with leukemia didn't sin to get the leukemia, as he would mention. So we live in a world, and in a way, we all are going to die unless the Lord comes before we die. We all will die. And in fact, that's why Christ had to become a human in order to die, because the nature of being a human being is that you can have a physical death. He was never spiritually dead, but he did experience. So man will return to dust, which is physical death. And while he was spiritually dead, he was kept from immortality, because you would be in a fallen state, and really it's not until you die, obviously you're immediately spiritually alive when you accept Christ, but in order to really have the fulfillment of that, it's when you die and you're with the Lord. So I like this part of the City of God written by Augustine. For then, at the fall, death was occurred by sinning. Now righteousness is fulfilled by dying. So Christ came and died in righteousness. So death becomes the instrument by which life is reached. Death is good to none while it is being actually suffered, and that's the suffering aspect. And what we have to do, it's painful, it's difficult, so it's not really a good thing, but it's part of what we have to go through. But it is meritoriously endured for the sake of retaining or winning what is good. So we all have to go through, death is good to the good and evil to the evil. So when we die, death is good to us because we'll be with Christ. Those who are not, it's not good for them because they'll be eternally without God. And that brings us to the whole concept of futility. Futility is a very hot topic. And in fact, in a lot of ways, in the bioethics world and even in ethics in general, people are trying. The word is so has so much intensity with it that people really are trying to avoid even using it because it means so many different things to so many different people. It's actually one of the oldest concepts in medical ethics. There's reference to it in the Smith Papyrus, but in Hippocrates, and what it is in this sense, it's refused to treat those who are overmastered by their diseases, realizing that in such cases medicine is powerless. So futility talks about treatment, a treatment option, a therapeutic intervention, not about a person. A person is not futile, care is not futile, but treatments may not be medically effective. And we'll talk a little bit about how that might work. So it's a central notion in end-of-life issues, and it's a very emotionally laden topic. So there's been attempts to try and define futility. Physiologic futility is the treatment will not work. It's absolutely, if there's no point in giving a blood transfusion to someone who's been decapitated. That's a absolute physiologic futility. That treatment will not work. But then you have quantitative futility. Well, the treatment probably won't work. Well, it's probably like 1 out of 100 or 1 out of 1,000,000, so that it's hard to define. And then you have the most controversial is quantitative futility. Treatment will not have a beneficial outcome. The quality of life, as the Germans would say, life not worth living, or useless eaters. We don't want to keep somebody alive because we don't think that it's a benefit to society or costs too much money. Now, I like the term Dr. Pellegrino used. Dr. Pellegrino was a wonderful Christian man. He was a bioethicist, one almost considered the godfather of bioethics. He was at Georgetown University. He taught a lot at Trinity in the Center for Bioethics and Human Dignity. In fact, I was fortunate to take a course from him. And he's well respected, not just in the Christian community, but also in the secular ethics world too. He uses this term, and in the Journal of American Medical Association published it, although he's been using that before and after. He says that futility is the relationship among effectiveness, benefit, and burden of the treatment. Remember, treatment in question. Well, so what is the effectiveness of treatment? It's an assessment of the capacity of the treatment to alter the natural history of the disease. It's an objective determination within the province of clinical knowledge of the physician based on as much evidence, outcome studies, and prognosis as possible. We would call this today evidence-based medicine. That's what physicians are trained to use. You only use procedures that have been shown to be effective, that will actually change, that will do something. Okay, what about the benefit of the treatment? Determined by the patient's assessment of the value or desirability of the treatment's result. Not the treatment team, not a committee, but the patient. It's the province of the patient, helped by factual input from the physician, covers a wide range of things desired or sought by the patient. And what are the burdens of treatment? Cost, discomfort, pain, and inconvenience of the treatment in question includes the patient's quality of life assessment, determined by both the physician and the patient or surrogate acting together. So the saying is that there may be a treatment that is not horribly effective, but it might prolong someone's life for a while. It has some side effects. But let's say, for example, a woman has advanced lung cancer and there's a treatment that might extend her life 2 months. And she said, I want to see, my first grandchild's graduating from college in 6 weeks. I want to be able, So the benefit to the patient may outweigh the small effective treatment or even some of the burdens. So it's a balance depending upon that input, and rather than being a definitive ex officio decision made. Now, palliative care. Let's define what palliative care is. This is the World Health Organization's definition. It's the active total care of patients whose disease is not responsive to curable therapy, control of pain, other symptoms, and of psychological, social, and spiritual problems is paramount. The goal of palliative care is achievement of the best quality of life for the patient and their families without, now I added this, it's not from the WHO, but without compromising sanctity of life. So whenever you get into palliative care and hospice options, there's nothing wrong with those, and there's nothing wrong with quality of life. It's just you don't want to sacrifice the principles of sanctity of life. There's nothing wrong with trying to make somebody in less pain, feel better, enjoy the time they have left. There's nothing wrong with that. You just don't sacrifice that on the altar of saying they're not a person or they don't deserve to live. So it affirms life and regards death as a natural process. It neither hastens nor postpones death. Pain relief and relief of non-pain symptoms, offers support to patient to live as actively as possible, and offers support to family to help them cope with illness and bereavement. Now, palliative care is different than hospice. Palliative care can start at any point. If someone gets diagnosed with a stage 4 cancer, they may have 2 years theoretically left to live. And they want to get chemotherapy and they want to have things, but you can also get palliative care. Palliative care is a way of coping with those that have an illness that isn't expected to be cured. Now, heard the talk this morning on miracles. Things can happen, but in general, that's the concept of it. So now what is hospice? And a lot of people misunderstand what hospice. Hospice is palliative care provided to terminally ill patients. The Medicare hospice benefit specifies, and everybody kind of lives on what Medicare says, the other insurance companies often follow suit, that the attending physician must provide initial certification that the patient is terminally ill. Terminally ill is defined as a prognosis for life expectancy of 6 months or less. So what that means is, if you qualify, if your physician says that in all medical probability you have less than 6 months to live, you're eligible for a hospice benefit. You don't have to choose hospice. You can't be mandated to take hospice. But at any point in those last 6 months, you could switch to hospice care. What are the origins of hospice? Dame Cicely Sanders was the person who really started the modern hospice movement. She was a nurse and then later became a physician, and she was at St. Christopher's Hospital in London and started the first hospice in 1967. She was a committed Christian. She had an adult life conversion, became a very serious Christian, ministered to those who were terminally ill and with extensive pain. She was strongly opposed to euthanasia. In fact, that's one of the reasons she designed the hospice movement, was as an alternative to euthanasia and assisted suicide. So she wanted to use effective pain management as always possible, and she's often quoted, this is one of her most quoted statements, "You matter because you are you, and you matter to the last moment of your life." Now, fear of dying. Fear of dying has two: the fear of non-existence and the fear of how death will occur. Those are very common fears. And what better way to minister as Christians to those than those who are dying into these aspects? Now, obviously, those who are in hospice and physicians and nurses can do the second part, but the first one is an opportunity to witness to people who are toward the end of their life, to comfort them, to give evidence that God is real, to move them from being bitter, understanding that their disease most likely was not from anything they did. So those are important facets. A book that's I think an excellent book, was written by John Dunlap. He's was a geriatric physician. He's also a physician who deals with geriatric patients, but anyway, he was on the he's on the Christian Medical Dental Association ethics committee. I've worked a lot with him. He's written a very good book called "Finishing Well to the Glory of God," and it's really good for anybody who maybe even be toward the end of their life, but also for those who might minister to those. And it emphasizes living well, let go graciously, treasure God's love Him in return, grow through adversity, like we heard about Job, and embrace a biblical view of life and death, complete your agenda, make appropriate use of medical technology, changing gears from cure to comfort care when that might be appropriate, and to rest in Jesus. And he has written in this book, and this is part of the statement that the CMDA has on advanced directives. Oh, I'll show you that. Let's talk about what an advanced directive is. It can be, at least in Texas, it's 3 parts. You can have a directive to physicians, which is a living will, a healthcare power of attorney, and an out-of-hospital do not resuscitate document. Of those 3, clearly the middle one, I think, is the most important. You need to assign someone that's willing to do that to be your decision maker when you can't make decisions any longer. And that person needs to know what your values are. Hopefully it'll be someone who shares your values, so it's not just rotely doing what you want. But it's somebody who you've discussed it with. It's most of the time your spouse if you're married, but sometimes it doesn't have to be, particularly in the elderly population. Sometimes it's hard. It's very hard for people to make decisions that are spouse. Sometimes people are suffering with some dementia who's a partner. So sometimes an adult child might be a better choice. But That's clearly the person that physicians will go to. You can have a living will, and it's helpful, but it's most helpful to the decision maker, and the decision maker is the healthcare power of attorney. If you don't have one assigned, the state will assign you one, and it's usually in the logical order. It's usually a spouse, and if not, a parent or an adult child, and it goes down the line. But if you want somebody different than what the state says, and it's even better to always acknowledge that, because they will be asked to interpret your healthcare power of attorney. Because let's say someone says, I don't ever want to be on a respirator. Well, they have a gallbladder attack, they're taken to the operating room, and the anesthesiologist gives them a drug that paralyzes them and puts them on a respirator so they can have an operation. Well, somebody does, and you call up and say, take them off the respirator? No. So there has to, now that's an extreme, kind of ridiculous case, but we have had situations not unlike those, and so you have to have somebody that interprets that, and they will always give deference to that person. So if there has to be somebody that interprets your living will, it's going to be your healthcare power of attorney. So to me, that's the most important person and the most important decision to have. So an example that you could put in this living will, which is an example that Dr. Dunlop has and the CMDA has on their section on advanced directive, and it's just an example. There may be areas that you wouldn't want to use or speak that way, but just as an example, this is one that he wrote. He said, I consider physical life a blessing from God. It is my physical life that he has led me to faith in Jesus and that assures my eternal life in heaven with God. I believe he has left me on earth to do his work in serving others. If there is a reasonable chance that I will be able to provide spiritual service to others, I desire medical technology to preserve that function. However, if by reasons of spiritual, emotional, mental, or physical infirmity, I am no longer able to serve others, I do not want my life prolonged. At no time do I want anything done that would actively terminate my physical life. If there is uncertainty as to whether I will recover sufficiently to serve others, and if it is elected to use some technology to prolong my life, then after a reasonable period, if I've not recovered, I want that technology discontinued. Now you can see that's rather vague. And so it's open to interpretation. It's open to interpretation it gives some latitude to the person making that decision. Some of you may want it to be stronger and more specific, but it's a statement of what your values are, and that's helpful. And it's the person it's the most helpful for is your medical power of attorney, because just in reality, life at the bedside, what the physicians usually want, eyeball to eyeball, they want a person to talk to about the decisions. So yes, you can have it written down, but they're gonna want a confirmation or an interpretation. So it probably helps the decision maker or the medical power of attorney more than it helps the physician to have some statement like that. Now, there was a very interesting article in the Journal of the American Medical Association, August 17th, called The Care of the Patient by Francis Peabody. It says the most common criticism made at present by older practitioners is that young graduates have been taught a great deal about the mechanism of disease, but very little about the practice of medicine. Or to put it more bluntly, they are too scientific and do not know how to take care of patients. Now, I said that was in March 17th, but I didn't tell you what year it was. That was 1927. And it was a lecture given by Dr. Peabody at Harvard Medical School. And he says at the end of his talk, the secret of the care of the patient is in caring for the patient. So the goals of medicine, and this is a quote that People have attributed to many different people. No one really knows where it came from, but it's to cure sometimes, to heal often, and to comfort always. So what can I do to be a voice for God in this area? Volunteer at a local crisis pregnancy center, volunteer at a local hospice organization. Until you really know what they do, don't be too critical of them. They really do, most of them do good work. Find out what local politicians believe about key bioethical issues and vote accordingly. Volunteer to pray for local politicians, doctors, social workers, school counselors. Volunteer at your local hospital and see if there are any open volunteer positions on the ethics committee. Most ethics committee will have a community member assigned to represent values of the community. Contact Christian organizations that are working to set policy regarding these tough issues and offer your prayers, monetary gifts, and time. And read quality books on bioethics that when you are asked about these issues, you can give a reasoned Christian response. And again, remember those websites that I put up in the first session that are very helpful.